My name is Unni Narayanan. I am a staff paediatric orthopaedic surgeon at the Hospital for Sick Children and an associate professor with the Department of Surgery at the University of Toronto. As part of my role as a paediatric orthopaedic surgeon at the Hospital for Sick Children, I am also a consultant here at the Grandview Children's Rehabilitation Centre, and I've been involved with the centre for approximately 11 or 12 years. My area of clinical interest is in cerebral palsy and lower limb deformity work, and my interest in cerebral palsy takes me to 2 or 3 off-sites or rehabilitation centres, Grandview being one of them. So as a consultant, I come to Grandview approximately once a month, so that might translate to about 10 to 12 clinics a year. I see on average between 12 and 15 patients at each clinic appointment. Most of those are from Grandview, and between 3 and 6 might be from the 5 Counties Children's Centre in Peterborough. That might attend this particular site for their outpatient services as well. So altogether that would be somewhere between 100 to 120 clients that come from Grandview. So children with cerebral palsy are looked after by clinicians from multiple disciplines. Cerebral palsy basically involves movement disorders, disorders of movement and posture secondary to a problem that arose from some insult or injury that occurred to the brain while it was still developing. Some of the most significant consequences of this primary problem in the brain are problems with the musculoskeletal system. So because they've got tight muscles and weak muscles and they've got bony deformities, they develop contractures and deformities in their trunk and their limbs that can impact the way they function. And there's a broad spectrum of involvement. Some kids are able to walk, albeit with some difficulties or challenges, and other kids rely on wheelchairs for most of their mobility and are reliant on parents or carers for most of their activities of daily living. So depending on the extent of their involvement, our goals for our interventions can be quite different. But essentially the role of the orthopaedic surgeon is to deal with the contractures and bony deformities that have evolved over time in children for whom the non-operative interventions that are absolutely an essential part of their initial management have stopped working or are no longer effective. So early on in their management, they're looked after by physiotherapists who work on stretching and strengthening. These kids are managed by orthotists who make braces that are very important parts of their treatment. Development pediatricians and physiatrists work on some of the non-operative aspects and certainly non-orthopedic aspects. Many of these children are candidates for management of their spasticity by medical means, so botulinum toxin injections, for example, and these are effective in trying to delay or prevent the onset of fixed contractures that then require the services of an orthopedic surgeon, where these muscles are now too short for the distances that they have to traverse and can only be dealt with actual operations to lengthen them. Or if there are bony deformities that are fixed, then those have to be corrected to maximize the potential of these kids to function in their environment. Children with cerebral palsy have tight muscles because the normal signals that come from the brain to get the muscles to relax is what's missing. Muscles grow by stretch, and for kids with cerebral palsy who tend to develop their milestones, that is when they first walk, if they do walk at all, can occur much later than the typically developing child. doesn't get the kind of stretch to their muscles that allows the muscles to grow. In addition, these muscles are very tight, and which is another reason why the muscle doesn't get a chance to stretch. And without that adequate stretch, the muscle is not going to grow in pace with the bones, which grow because there are growth centers in the bones. So over time, a muscle that's quite tight also becomes too short for the distance it has to traverse to allow it to function normally. And in children with cerebral palsy, as they're growing, and they grow until they're about 14 or 15 if they're girls, until they're about 17 or 18 if they're boys, during that time is when these tight muscles become too short and develop what we call our contractures. So all our interventions early on are trying to avoid me. It's trying to keep those muscles stretched artificially with physiotherapy, with braces to maintain that stretch, with Botox to help relax the muscle, to make it more easy to stretch, casts to stretch the muscles. But at some point that's insufficient to allow the muscle to grow in pace with the bones. And that's when we have to come in. So orthopedic surgery largely involves lengthening the muscles that are too short. And depending on what kind of muscle it is, the way we lengthen it can be quite different. In addition, these muscles attach to different bones. And because of the abnormal forces on the bones, these bones that are growing as a child is growing also change their shape. And they take on abnormal shapes that can further aggravate the problems. And so part of the orthopedic surgery involves correcting these bony deformities as well. So these operations are at multiple levels and all done simultaneously. There was a time when these operations were done one level at a time, first at the foot and ankle, then at the knee, and then at the hip. And this was spaced over the age of the child. And we realized that this was just subjecting kids to multiple operations over their growing years, and realized that that was not a very efficient way of doing things. These kids were spending a lot of time in the hospital recovering from each subsequent operation. So today, our general philosophy is to try and delay the operations until they're a little older, somewhere between 8 and 11 to 12 years of age is that sweet spot, so that we can do all the operations at once so they can then recover, have one recovery. So the operations are done at the Hospital for Sick Children, and again, the types of operations we do depend on whether we're talking about a child who's able to walk, in which case they're to try and improve their ability to walk, and for children who are in wheelchairs but have hip dislocations, spinal deformities, then we're doing operations to reconstruct the hips or correct the spinal deformity. Following the operation, because of the extent of these surgeries, it takes somewhere between 6 weeks to 6 months to recover from them. Some children take advantage of an inpatient rehab stay at the Holland Grandview Kids Rehabilitation Hospital. Other kids take advantage of the excellent postoperative care that's available here by outstanding physiotherapists who really know the patients very well. They have access to the school, so they can come to the school on a daily basis. As a day patient can get the physiotherapy here as well. And so different families will decide which is most optimal for them, and many of the patients from Grandview will choose to have their post-operative care done here at Grandview rather than as an inpatient at Holland Grandview, which is, I think, great advantage to them because they're a lot closer to their homes over here. Following surgery, surgery can only be successful with very intensive physiotherapy, and this is where we rely very greatly on the services of the therapists here, who are excellent and know these kids very well, and can bring them back to their full potential. So it depends on how severely involved the child is. If you take a child who is able to walk but relies on a walking aid of some kind, like crutches or a walker, as they get bigger and heavier and taller, their contractures. This is where their muscle length comes short and their bony deformities start to increase to the point where the physical effort to walk to get from A to B becomes overwhelming, that they become more and more reliant on a wheelchair. And a wheelchair is a very useful way of getting from A to B, but may not be practical in every situation. So for the ambulant child, the child who can walk, many of them are at risk of losing the ability to walk independently, even with a walking aid, if left untreated over time. At the more severe end of the spectrum, these are children who can't walk and are unlikely to ever walk. Left untreated, they are at a very high risk of developing hip dislocations, a very significant majority of which can become painful, with the contractures interfering with dressing, hygiene, and looking after them, positioning them, and so on. Many of these kids are also at risk for developing spinal deformities, which can then affect their ability to sit comfortably and sit upright. So not every child is a candidate for orthopedic surgery, but a significant proportion are, and it depends on which end of the spectrum of involvement they are. The primary problem for kids with cerebral palsy is really up in the brain. The peripheral consequences are in the tight and weak muscles that they have and in the bony deformities that they get. And so we subject these kids to major interventions, big operations, with the expectation that that will translate into something useful for these kids. So those kids who can walk, hopefully these interventions will make them walk better, allow them to be more independent. For kids who are unable to walk, they're at risk for developing hip dislocations, where the hip can come out of the socket, which can become quite painful. They can get contractures in their muscles, which are very tight, that make it very difficult to look after them, to dress them, to transport them. They get spinal deformities that can make it very difficult to support them upright. And we do these big operations to try and straighten spines out, put the hips back in place, and to correct these contractures. And the question remains, how are we helping these kids? Are we really making an impact to their quality of life, making them more comfortable, making it easy to look after them when we're talking about the kids at the most severe end of the spectrum? And in the kids who are able to walk, do we actually make them walk better? We know that we can make them walk differently, but is that difference actually meaningful? As far as the kids who are able to walk, many of these kids are subjected to these big operations. Prior to the operations, we do a special test called a gait analysis, which is a special way of evaluating a child's walking in a motion laboratory, which is located at the Holland Grandview Kids Rehabilitation Hospital. The gait analysis, which is derived from this motion lab, is currently not funded through OHIP. Many centers don't have access to a gait lab. Many orthopedic surgeons feel that we should not be doing these operations for these kids without information from gait analysis, and other surgeons who don't have access to a gait lab believe that it may not be necessary. We really need to know if that is true or not, and so I'm leading a randomized trial, which is a clinical trial, to try and answer that question. This is also funded by the Canadian Institute of Health Research. So all kids, including kids from here at Grandview, who are candidates for these big operations to help them walk better, have a gait analysis done prior to their surgery at Holland Grandview Centre, so that we can answer the question, with and without this gait analysis, are their outcomes better or improved? As part of that study, we're also developing a new outcome measure to determine how best to know that we're making a difference that's meaningful to these kids by talking to them and getting information from them about what it is that they really want from these operations. And we've developed an outcome measure to do that, which we're currently validating And so a lot of the clients here at Grandview are contributing to that study as well. So my research interests are trying to define what is better, is trying to understand from a child's perspective and or their parents' perspective what's really important to them in terms of what a meaningful difference will be. And using that information then to develop outcome measures that incorporate those priorities of those important differences, so that when we ask ourselves, is our treatment making a difference, we can use these outcome measures that incorporate or embed within them the priorities that they've told us are important. And a lot of my work over the last decade has been to develop these outcome measures, both for the kids at the severe end of the spectrum and now for the ambulant children as well. And then to use these tools in clinical trials where we can actually evaluate the effectiveness of our interventions and generate evidence that can then be translated to other jurisdictions where we can say we now have evidence that treatment A is better than treatment B and that we're really making a difference. So it's measuring outcomes and testing these outcome measures in clinical trials to know that we're really making a difference is what my research is about. There are three primary projects that I'm currently leading. Again, a good way to describe them would be think of the population of kids with cerebral palsy who can walk, and the population of kids with cerebral palsy who are more severely involved, who are unable to walk. For the latter population, we've done a lot of work on developing an outcome measure that now has the ability to determine whether we're making a meaningful difference to their lives with the operation that we're doing, particularly related to putting their hips back in if their hips are coming out, or straightening their spines out to address the spinal deformities that these kids are at risk for. We have recently just secured a large grant through the Canadian Institutes of Health Research to study how effective our interventions are to manage the hip in cerebral palsy. This is an international multi-center study that I'm leading that will involve about 13 countries with about 22 centers so far, looking at the different ways that we manage the hip, which in the next 5 years we hope to be able to provide some answers about which are the most effective ways in doing this in terms that parents and children will be able to say are the best. A major focus of my practice is looking after children with cerebral palsy, and I spread that work between 4 centers. So I see some kids with cerebral palsy, but most of the cerebral palsy work is done at Blowview here at Grandview, Oak, and the Five-County Children's Center. And the Grandview Children's Center is one of my favorite places to go to, because the care that they receive here by the therapists here and their development pediatricians and their physiatrists is really exceptional. And it's great to get first-hand information from the kids' therapists who attend the clinics along with the kids, and I know for sure that after their operations they're in really good hands in terms of therapy that they get. So it's a pleasure to come here.